All right, everyone. Welcome to our chat, monthly chat, September 1st. And today we'll be going over part 2 of kidney transplantation. This is going to be a 60-minute event, and we have some very powerful speakers today. We also want to keep it interactive. So if you have any questions, please do put that in the Q&A box. But besides that, if there are any comments that you want to make, probably just keep them to yourself at this point, and you can email them to us, unless there's just a comment to share about the presentation itself. With that, my name is Anjay Rastogi. I'm from UCLA. I'm a nephrologist and a pharmacologist. Green ribbon, as you probably all know by now, signifies kidney disease in our fight to end kidney disease. This is a disclaimer. It's very important. Anything that's discussed here is only for your information. Please do not make any changes in your care till you speak to your healthcare provider. I think that's they know you the best. This is our contact information. That's our direct office line, 310-954-2692. Email address is pretty straightforward as well, coreKidney@mednet.ucla.edu. And then also we have a Facebook page that you should follow, and also our website. There's a lot of very useful information that you'll find on these social medias, and also updates about our programs as we do more and more similar programs down the line. So this is our contact information. If you have any other questions, feel free to let us know. This program is being recorded. The previous one was posted. We have actually on YouTube. I think, Christina, we should put this over here in YouTube as well. We have 2 channels. One is called Core Kidney for healthcare providers, and the other one is Core Kidney for patients. So all these videos eventually, or recordings eventually, end up on those YouTube channels. So Core Kidney YouTube channels, please do visit them. Now, this is our Circle of Core. This is our patient advocacy group. These are patients who have been previously on dialysis or have chronic kidney disease, have been on clinical trials, have been transplanted, and some of them are actually living kidney donors. And this is, I think, one of our biggest strengths of the Core Kidney, if you ask me, is probably this picture. And this is, there are more members that have been added to this, but nobody can walk you through the process more than somebody who has been through that, whether it be a recipient or it be a living kidney donor. And with that, I would like to welcome my co-host, Mark Coronel. I'm sure most of you know him, have heard him, a very inspirational speaker and individual. And he will just give a few comments on patient advocacy and his role in the Circle of Core. Mark?
Thank you, Doc. Thank you so much. Hello, everybody. My name is Mark Coronel. I'm the Core Kidney Lead Ambassador for the program. And if you guys have any questions about what the Core Kidney does, it consists of donors, recipients, caregivers who've actually gone through the process that you're actually going through. And in today's conversation, we're going to be discussing how transplant actually changed my life. And for me, I was on dialysis for 3 hours a day, every other day. And that was really, really overwhelming to my body. And what you should know about transplant. So from dialysis to getting this letter that says you have been approved to going through the transplant department is one of the best things that ever happened to me, because I needed to make sure that when I was going through the transplant evaluation, I needed to be prepared. What did that consist of? You're going to be going through blood labs. They're going to be interviewing you and making sure that you are disciplined to take your medications and making sure that you have a caregiver, because the first 3 to 6 months was really, really hard for me to readjust because of my incision. I'm getting back to normal life. But not only that, I was able to urinate again, right? So on dialysis for 2 years, I wasn't able to urinate. And once that kidney actually hit my body, I was able to do that again. So that was one of the most amazing things that happened for me, but also the evaluation with the medications, making sure that you guys take that on time. And that's going to be what our discussion will be today. And I'm really excited to share with you guys by having all these healthcare professionals today to actually run it through the process. With that, Dr. Rastogi, thank you so much.
Thank you. Thank you so much, Mark. I also want to take a moment to thank Christina Lopez and her team that are working in in the background, and they make these kind of events happen. I also want to thank our undergraduate club, Brewing Beans Health Club. That is our our future in healthcare. I want to thank them too. They're providing all the support they can. And then we have our resident psychologist, psychotherapist, our dear friend, Jim Cunningham, who's also, as always, joining our program. Jim, do you want to say a few words? The role of a psychologist, and I always go through this, is very significant, especially in this time of the COVID. But this journey that a patient goes through with kidney disease, whether it be and we don't use the word pre-dialysis, we call chronic kidney disease, or dialysis and transplantation. The role of a good psychologist, psychotherapist is very, very critical. And Jim has taken care of a lot of my patients and it really helped them. So Jim, do you want to come on camera for a second and say a couple of words? All right, there he is.
Sure. I don't want to get in the way of what Mark's going to start with, because I like the presentation and I like the introduction he just gave. But for the most part, I guess it's about regulatory rules or tools as well that have people kind of go to each stage and support systems and structure and network and being more accountable for their health. That's some of the conversations that we kind of throw around when somebody's in the precursory stages. But and everybody's unique, everybody's individual. So I think that at this point, I think that's probably what's pertinent for people to understand.
Yeah. No, I think the key word that you use is to hold yourself accountable. And I think it's a teamwork. We always say that the healthcare team and the patient and their loved ones, and we all work together. And our job as the healthcare team is to provide you the right resources. And the reason why I say right is because there are a lot of resources, and most of them actually could be quite misleading. And one of the things that we do in chat on any of these events that we put together for our patients, everything is science and evidence-based. This is not somebody's own opinions, but it's what the science backs up. So getting the right source is very, very important. And that's where also our patient advocates come in. And Mark said that and I consider Jim to be our ambassador as well. And it's giving them the right information. This is information that we supervise as a UCLA core kidney program. These are not just individuals who are speaking on their own. And that includes me as well, by the way. So we have. So with that, Jim, thank you so much.
Can I just say one more thing?
Absolutely, 100%.
One of the things that's become paramount in my understanding of all of the way this whole process works is the aspect of collateral resources and inclusion, and how people kind of learn the network and start relying on each other to get them to a place where, they live a highly qualitative life after they go through the procedure.
Right.
So that's all I have to say.
Okay, thank you. And you'll be making comments as needed, and so will be Mark throughout the event if you want to highlight or emphasize something that is important from a patient's perspective. So thank you so much, Jim. Yeah. Thanks for all that you do for our patients. Very much appreciated. So with that, let's talk about transplantation. The part one was last month. And then the next month we have time, that's October 1st, we'll have Tammy Winchell, our living kidney donor, and she's actually writing a book on living kidney donation, what you should know. So she'll be discussing that, and she will be moderating that event with me on October 1st. So please do stay tuned in. And if you have individuals that want to donate their kidney or might want to consider, this will be a very good event for them to attend. Also keep in mind, there is also the voucher program. And if a person is coming in with a GFR of 30 and 40 and they don't need a transplant right now or will ever need a transplant, hopefully, but they have somebody, a loved one who wants to donate, they can donate on their behalf. And if they ever need a kidney transplantation themselves, the patient, they go on top of the list. And we'll be discussing the voucher program, the payer exchange program in a lot more detail on October 1st, our next chat. Once again, these programs are going to be 60 minutes each, so we will not be going over that. And if there is some stuff that we have to cover, we'll cover it in the next. So as we continue our kidney transplantation journey, two people that I want to introduce, my very dear colleagues, Dr. Sarkar, who's going to be doing the main presentation. She's our transplant nephrologist as well, and Dr. Shah, who's actually a very senior transplant nephrologist, has run multiple transplant programs as medical director, and he will be joining and giving his expert comments on this as well. So Dr. Shah, if you want to just come on and say hello to everybody if possible, but otherwise, Dr. Sarkar, you can take it from over here. And that's the Dr. Shah.
Hello, everybody. Good afternoon. Thank you.
Thank you. And, you know, the questions that are being put in the Q&A section, Dr. Shah, Dr. Sarkar, and all of us will be answering them. So with that, Dr. Sarkar, you can take it from over here.
Sure. Hello, everyone. Very good evening. Thank you for joining in. Thank you for trying to listen in. My name is Mrinalini Sarkar. So if you Google me, that you'll find my name as Mrinalini. I go by Molly for ease of conversation, I would say. I'm going to be talking to you about kidney transplantation. I call this the before, the after, and the happily ever after, and couldn't say Mark couldn't have stated it better. Peeing after a long time is such a surprise to all your transplant patients. That is something that is the most life-changing event that happens so fast. Hence, let's talk about how we get to happily peeing after. Next slide, please. So I am basing this conversation on three premises that I think are very central to both the core kidney program and UCLA as well. One is that the patients that we deal with and the patients that come to us or we meet in general are very intelligent, and patients want to know and they want a partner. So the idea is to teach and learn. Next step. But with that being said, I do want you to consider this as your safe space. No question is a dumb question. No question is silly. I want you to help to be finding help with us, feeling that we are your friends and can help you. Next. And then more importantly, tell us about yourself, because it's important to know you. Each transplant recipient, as you know, is different. Each transplant that we do, if we did 437 in UCLA last year, each of those 437 were unique people getting unique transplant in their own unique situations. So next, please. So with this, I think we're going to start this conversation, talk about transplantation. So what I'm going to cover in this whole discussion is why have a kidney transplant, why even talk about it, who should, who can get a kidney transplant, what is the waiting list and what it means to be on this waiting list. What does it mean to be a match to somebody? What is an evaluation process and what all is considered in an evaluation process? What are the different types, the kinds of kidney transplants that become available to you once you're considered a candidate, and some of the other medical issues that surround transplant surgery and transplantation in general. Next slide. So before we get started, like when we talk of transplantation, we should understand some core things. So ESRD is end-stage renal disease, when your kidneys have been declared not being able to function independently on their own, and some kind of support is needed. That is where the conversations of dialysis have been coming in. CKD is chronic kidney disease that kind of spreads through the whole spectrum of 5 stages. Most of you know about it's how your GFR kind of progresses during the course of time. And eventually transplantation or dialysis comes in. It does carry a global health burden. So 2.5 million patients approximately are suffering with this disease. And very importantly, being on dialysis is not the only answer you have. Being on dialysis is actually pretty bad. There was a very fantastic study in 2019 that was done that looked at survival in patients with cancer and comparing that survival in patients with dialysis. Dialysis actually did pretty poorly when compared to cancers as like colorectal and like prostate. Colorectal is pretty devastating in itself. Next slide, please.
So, Dr. Sarkar, just one comment about this. I think this is a very powerful piece of information that,
Yes.
when we look at modalities and options that you have for patients with end-stage kidney disease or advanced kidney disease, transplantation and hopefully preemptive transplant is probably the way to go. But for that, you also need a living kidney donor, and then dialysis, home dialysis. And you're absolutely right. We have to keep in mind but also the place where you get care is very important as well, because these are all comers, right? They're patients who have not had optimal starts for the dialysis. So I've lived, the last 17 years in this dialysis. So yes, the dialysis is something that we want to avoid, but a lot of patients do fairly well, right? I mean, they have, they can live on this chronically, and there's some patients who have. So the outcomes on transplant is the best option for majority of patients. And then try to get home dialysis. PD is, and also go to centers and places that actually are proactive and take care of themselves. So I just want to put my 2 cents in that. Sure, next slide.
Thanks, Dr. Yeah.
Sure.
Okay, so going back to I think Dr. Rastogi interrupted appropriately. So about talking about transplant versus dialysis. So looking in terms of where we spend our healthcare dollars and how it comes back to us, and not just that, looking in terms of survival, transplantation seems to find itself gaining benefit as we move beyond a year. So if you see on the left side, cost in dollars at around a year to 2 year time frame, and as you see at around 180 days, the risk of the survival actually starts to gain benefit. And hence this whole conversation about getting a transplant, hence this whole idea about talking about transplant early, getting you engaged, getting everybody to think, start, talk, and understand it. Next slide. So what essentially is a kidney transplant? So a kidney transplant is a surgery you have to go through. It's done to replace a deceased kidney. So the kidney that has gone through chronic kidney disease process and cannot function independently itself, with a healthy kidney from a donor. The donor could be a living or could be a deceased donor or a person that has passed away. On the right side, I kind of highlight, because this question comes up many a times, what happens to my old kidneys when I get a new kidney? Most of the times, the kidneys stay intact inside your body when the surgeon puts in a new kidney. They just get added on. Next slide, please. So the surgery basically consists, as I said, you find a donor kidney. It could be a living, it could be a deceased. The surgeon puts it into your body, most commonly in the right lower quadrant focus, so right lower part of your abdomen, sometimes in the left part, depending on how your abdominal cavity has been structured. There is a stent that comes in that connects from the ureter. So this is the surgical part of it. The kidneys connections are made, both the blood vessels and the ureter is connected. There's a stent that is placed. Occasionally, there's a small little bulb that stands outside, depending on how the surgery went. This bulb kind of captures excess fluid and stops any swelling from developing around the kidney. And this is how, at the bottom picture, a typical kidney scar looks like. So nothing pretty extensive, not so very uncosmetic either. Next slide, please. So essentially, we're asking for a healthy kidney. We're asking for a fantastic bunch of surgeons. That's actually UCLA surgeons operating on a kidney transplant. And we are asking a recipient that's ready. And hence, this is the whole recipe for getting a successful kidney transplant. Next slide, please. So importantly, I mean, I'm going to bring in a historical perspective because I think it's important to understand, and some of the aspects that we're going to talk about in the future will come into play too. So humans have been trying to transplant organs as early as 1909. However, only in the late 1950s is when we started to do these human-to-human attempts in a more intense manner. So in 1952 is where our first deceased donor kind of transplant came into play. But remember, the kidney only functioned 22 days and kind of rejected the body. This is also the era where there was no immunosuppression in place. However, in 1954, this was the first time we got a kidney donation happen that was successful. So this was a donation between two identical twins The person had nephritis and they had kidney failure and they were about to die. And his sibling decided, his identical twin brother decided to give him a kidney. So what happened to them? Next slide, please. So the person who received, Richard, basically his kidney functioned 8 years. Now, again, remember, this is without immunosuppression. He died from complications apart from kidney failure, not related to it. He actually ended up marrying a nurse who cared for him in the recovery room, had 2 kids, lived a pretty happy life. This is way back in 1950s. His brother, who donated him a kidney and was a donor, lived until the age 79, and once again, only died after complications of heart surgery, not related to his kidney. So even then, in that era, you were talking when you had donations, donation was safe, was found to be safe, and recipient did very well compared to whatever we had in the past. Next slide, please. So what are the types of kidney transplant you can get? So you can either have a person who is living and is a compatible donor to you. So this is called living donation. So you can have either a person who's a matched and compatible donor, or now we have options of going through paired or import exchanges. So you can have people exchange kidneys. You can go through a chain. Dr. Rastogi also alluded to a voucher program. You can give ahead of time and get in a kidney later. The next step is if you do not have a living donor available, you go through the process of what's called deceased donation, where you get on a list and with a particular transplant center, and you kind of wait for a well-matched kidney. And in rare occasions, certain centers go through what's the process called desensitization. Next slide, please. So I think Dr. Rastogi also mentioned the word preemptive. So what is preemptive and why even think about it? So what is a preemptive transplant? A preemptive transplant would be getting a transplant before you need to start dialysis. It would help you avoid dialysis altogether. Now, next slide, please. Does it matter if you have a preemptive transplant or not? So going back to Dr. Rastogi's conversation again, looking at the graph on the very left side, being on the waiting list, so kind of being on dialysis, compare that to being a recipient or getting a kidney from a deceased person, and more so getting a kidney from a living person. You have a definite survival benefit. Now, if I were to do a preemptive transplant, so I get a transplant before I get started on dialysis, and whether it comes from a deceased donor, as seen on the big graph on the left side, or from a living donor, as seen on the graph on the right side, you have definite both patient survival benefit as well as graft survival benefit. So what is a graft? A graft is basically what you call the kidney that is being donated to you. In medical terms, it's called an allograft. Next slide, please. So putting it together, you kind of find yourself in this matrix of 4 kinds of transplants. So you are getting a living donor, but you're getting a kidney transplant before you started dialysis. So you become preemptive. You get a deceased donor and you haven't started dialysis. So you're a deceased donor kidney transplant, but preemptive. And then you may be getting a living donor, but you've started dialysis. And the final is you're waiting for a deceased donor transplant and you eventually get it, but you're now started on dialysis. And as we talked, the goal of all of these things is to get you most likely a living donation, most likely before you start transplanting, before you start dialysis, I'm sorry, or what's called a preemptive transplant. Next slide, please. So what is the time we need to start talking about getting a transplant? So all of us know about CKD stages, right? So we walk through CKD stage 1, 2, 3, 4, and 5. These stages are roughly divided based on what your glomerular filtration rate sits, or what's called your GFR. Once you reach the GFR of around 30 or under, your doctor kind of decides if you have the ability to kind of stay there, or I think, is this the time to start talking about transplant, get discussion about transplant education, or talk to about a transplant center. And stage 5 kidney failure is really where you have a GFR of less than 15, or the patient is starting on dialysis, and we're talking initial renal replacement therapy. So put together, the bottom line is referral to a transplant center when the GFR is kind of hanging around in the 20 to 25 milliliters per minute range is appropriate. It's a good time to start talking with your doctor. It's a good time to start thinking about transplantation. Next slide, please. So what are some of the rules and regulations that transplant centers kind of find themselves, or the patients kind of find themselves confused when it comes to getting listed? So OPTN, or the Organ Procurement and Transplantation Network, is kind of what's the network that makes all the policies surrounding these wait lists. So patients can gather waiting time. So when you get on the list and you're made active on the list, and you can start gaining time in terms of years or months for getting a deceased donor coming your way, starts after you get 20, your GFR is less than 20 or equal to 20 milliliters per minute. This is just a policy that every transplant center has to follow. If you have had been on dialysis before this will count towards this waiting time. And this will count only if you've been registered on this list. So when you're on dialysis, you go to a transplant center. Let's say you were on dialysis for 4 years. You go to a transplant center, you get approved, and you're on that list. You have those 4 years to your waiting time added. That's also called the word back crediting, right? So this is valid only for patients receiving dialysis. If you are not on dialysis, this back crediting time does not occur. Only if you're listed and get your GFR under 20 is when the clock will start for you. So this word and this semantic of like GFR less than 20 and whether am I or not on dialysis kind of becomes important when you go through your evaluation process. Next slide, please. So what is this evaluation that I'm talking about? What does it mean to be evaluated for a transplant? So evaluation is basically your nephrologist or you yourself refer yourself to a transplant center that expertises in doing transplants. It's basically a medical interview. You go to the center. That's actually Dr. Danovich, who's the medical director of the UCLA kidney transplant, doing an evaluation, walking a patient to an evaluation room. This is your introduction to the team that can potentially take care of you in the future for your entire journey of transplant. So here is where you'll meet your team of doctors. You will meet your coordinators. You will meet your social workers. The doctors will sit and do a very comprehensive interview with you. They will evaluate your general health. They will ask you questions about how you feel, how things have been in terms of your medical problems in the past. How are you where you were? How did you come about getting kidney disease? Trying to know you in great details. This is also a basic interview where you get referred for certain kinds of imaging that you need. Most patients, if not all, get some blood work done as a part of an initial evaluation. This is trying to like understand your blood type, what kind of matches we can find for you. This is also the time of interview where you will see something called frailty come in. And I'll talk about frailty in the next slides in more detail because it's a very important concept. And then the doctors will talk about if you need any other consultations in regarding to your medical illnesses to be talking about with other doctors so you can have a stable and safe transplant surgery. And then are you up to date on your age-appropriate medical care? Look, we have recommendations from various societies for cancer screening, vaccinations, taking care of our health, our risk factors. The doctor will discuss all of that in this interview, and that is what evaluation is. Next slide, please. So what are some things that will come up as a no-no on this evaluation? What can stop you from getting on this list? Because I think the idea is to A, get a donor and a transplant, or B, get on this list. So what stops you from there? So active coronary disease, which basically means having an active heart disease, not a history, but having active symptoms like you get chest pain when you walk. You have heart failure that still needs to be treated by a cardiologist actively. You're having hospitalizations because of that. That is something that is considered a big no-no. Because remember, this evaluation is about safety for surgery. Active use of illicit substances, like somebody has been smoking cocaine or was doing cocaine or doing other substances. I will go into detail again about this. Having history of liver disease, what's called cirrhosis that's decompensated. Sometimes that generates a conversation about, trying to know if you need help with some other organ as well. It's not a complete no-no, remember, because there are transplants for your liver that happen too. And this is the evaluation which will help you understand if your liver needs help or if your heart needs help before we jump over to the kidney. Having systemic infections, very common. If you have diabetic foot, the infection has spilled into your bones. That is a very hard to treat infection. And remember, transplant is about suppressing your immune system. And that is not good if you have infections hiding in your body. This is also a time where we talk about like infections like tuberculosis, something that has the potential of getting activated when we put you on immunosuppression. If you have advanced stage other than kidney disease, like your COPD is so much so you need oxygen and cannot walk more than 2 steps, that's not a person who's as yet ready to get a kidney transplant. So the doctors will talk to you about how to better your health, how and what are your goals to get to that point in time. Very important that I put a star next to it is about atherosclerotic vascular disease. What does this mean? It basically means that your blood vessels in your body have these blockages built up. And it's a star because, it's not an absolute no-no. Every center, every surgeon is different. Certain centers expertise in very complex transplants, and this is where the surgical skill matters. So this is the time where the doctors will talk about and have a conversation about your risk factors. Another of such relative contraindication for getting a transplant is class 3 obesity. So your BMI starts to get above 40. Again, it's a moving target. Many centers advertise them by saying like, oh, we do transplant as high as 40. Many centers start to talk about having bariatric surgery at the BMI of 40. Many centers talk to you about bariatric surgery at 35. So it's a very center to center dependent thing. Again, surgical skill and the skill of your team kind of comes into play here. Again, the conversations are very individual to individual. Remember, you all will have a separate journey to transplantation. Or in all put together, your expected life expectancy is less than 5 years. There are other medical problems that are complicating the picture, and the doctor does not think you're going to be living beyond 5 years. That is a time I think they will not talk about transplantation with you, but trying to like get you better, or maybe trying to increase your life expectancy, move that needle beyond 5 years, and then get you talking about transplantation. Next slide, please. So I did talk about frailty, right? There was an assessment Dr. Danowich was doing of frailty. He had an elderly couple walking in that picture. Now that elderly couple was our oldest surviving transplant couple. They were living donors and they've completed 50 years on their kidney transplantations. They're one of the oldest ones in UCLA. But that tells you, and that kind of opens up a conversation about frailty. So a limited performance status is not just medical, but it also has, beyond the physical dimension, it also has a psychological dimension. It has a social dimension. You will be frail if you don't feel good. If you're depressed, you're not going to be motivated to get out of bed, walk around, do things, participate in your care. Lacking a robust social support system. One day is good, one day is bad. As Mark said, the first 3 months can be challenging because you were trying to balance. Life changed after a transplant. If you do not have a social support system, you will feel lost in this maze and you can lose your path. So it's important to kind of talk about that. Having insurance coverage, plan to cover costs, minor things, but sometimes when you are going through the medical system, it can take a toll on you. So they are kind of counted into this concept of frailty. being non-adherent to previously prescribed therapies. Fundamental thing after transplantation or with transplantation is taking your medication. That's a very important piece. Being there, following a schedule, following a time, basically how to take your medication. If you're not that kind of a person, if you're not there yet, I think you're still not ready for going through a transplant. This is the time the doctor should sit down and talk to you about, how to make things better. This evaluation and contraindications are not about saying no. These are about making things better, kind of going ahead from there. If you have poorly controlled psychiatric illnesses, they become very important. And hence you see like Dr. Cunningham as a part of a group, he's very essential. I cannot say more things about his role in this care. Not just you having or a patient having issues to begin with, how his basic psyche might be, the medications that get introduced post-transplantation can make things worse. There's a huge amount of steroid that's coming your way. There's a lot of other medications that will make you feel differently, think differently, can alter how we talk about our health, how we think about ourselves, and can impact your overall transplantation too. Untreated malignancy, or treated but kind of sitting in the period where we are not sure, or the doctor is not sure, or the medical literature does not give you clear guidelines if this can come back. Remember, immunosuppression or getting medications that suppress your immune system are also risk factors for developing cancers in the future. So all of this caution, all of this discussion kind of becomes part of your evaluation, and hence the emphasis on the evaluation. There's a lot that needs to be talked in that room. Next slide, please. So talking about listing and being on the wait list. So it's kind of transplant Tinder. So basically what the list is UNOS, which is the United Network for Organ Sharing, which is a countrywide organization, kind of makes this humongous list of patients who have kidney disease, have been deemed candidates for transplant, and now are waiting a kidney because they don't have donors available. And this list is kind of where you get put on. It's a nationwide list. And as the kidneys are coming and as the kidneys become available, depending on how good of a match are you, you are given a kidney. So kind of like Tinder. Now, what are some of the important aspects that go into this matching process? So very importantly, how much time have you spent on dialysis? Remember, your waiting years count. It gives you some benefit. Your blood type. Certain blood types have a shorter wait list time because you have more donors of that blood type available. Certain blood types are like so kind of frequent that it's hard to find a match and you have to wait a long time. Your age kind of plays into it. If you have certain kind of antigens and antibodies in your blood, I'll talk a little bit more about that. If you had an organ transplant before, or you need a transplant or 2 organs, or how far you're going to live from a possible donor, that kind of impacts how fast the kidney comes to you, becomes available to you. And then being on this waiting list basically means you are waiting for that big phone call to come for you. However, you're not just being passive about it. You're going to be seen by a transplant center on a yearly, 6-monthly basis. People will be constantly talking to you about making sure you're staying healthy. And it sometimes means yearly visits to your transplant center, kind of updating your health data if new things happened in your life, staying in touch with your coordinators, what I can do, how my life changed. Next slide, please. So summing it up, like, the process of transplant would be you get referred for evaluation. Remember the number of GFR less than 20. However, sometimes you can be referred to less than 20 when you're not needing dialysis. You will meet the doctors at evaluation. Maybe you find a donor before you start dialysis, and hence the yellow happy face, you get a preemptive transplant, or you kind of get listed, or you are not considered at that moment in time a candidate for transplantation. But however, moving forward, you kind of get dialysis initiated. You continue to stay actively listed. You get on this massive list and then you will find yourself getting a deceased donor kidney transplantation. Or sometimes if you still have those risk factors we briefly touched about, you'll be considered temporarily inactive, which is called status 7 in transplantation. So summing it up, remember, date of your start of dialysis is recorded in a form. You all sign this 2728 form. If patients start dialysis, that's the date the transplant center will use. They will use a GFR of less than 20 to kind of get you listed and active on this thing. And GFR of 20 is not necessary for evaluation, only for active listing. Clicking that button, clicking that box. Next slide, please. So talking now a little bit more about getting deeper into transplantation. So what does it mean to be a match? How be a match to somebody? Next slide, please. So number one, and most commonly known to people, is that, oh, we have a blood type compatibility follow. So we all are either O, A, B, or AB, and then we are either positive or negatives on all of these things. So a patient who is an O positive gets blood from O positive donor, or an O negative donor, however, cannot get it from A, B, or AB. So if you go to AB positive person, it's quite the opposite. He's getting blood from all of the people, especially AB positive. If it's negative, he's only getting it from all blood groups, but from the negative portions of it. So makes the O type negative as a universal acceptor. So kind of like universal donor, I apologize. So can give to everybody, because O and negative means they don't have any kind of like antigens that would spark a response in terms of blood groups. AB becomes universal recipient, which basically means they have A and B, both kind of antigens. So all kind of blood groups can find themselves getting entry. This is pretty much the same way it works for transplantation. So an O positive person kidney can get a kidney from O positive or an O negative, and AB can get it from approximately many people. And hence you see the list kind of gets shorter for different blood groups. So if you are AB positive, you may get by just being 5 years on a transplant list, versus an O positive donor has been waiting for like 10 some years. It's one of the most commonest group. There is an exception to it, and I put it right there on the right side. There are efforts, and it's a very well-established modality, that patients of B blood group are being provided transplants from A22. So you may see your transplant center introduce this conversation about A22 to B. Approximately every center in this country is doing it. It's a slightly higher risk transplant, but it's done very commonly. And as I can display in this graph, you notice it brought the transplant rates for people up to the AB point, which is AB is one of the fastest one to get off. Next slide, please. So more importantly, now we're getting a little bit deeper and trying to understand, more than blood groups, the transplant center is kind of going through other things that's happening in your body. And then there is this concept of histocompatibility. So histocompatibility, histo means tissue, compatibility means like beyond blood group, are two tissue pieces compatible with each other? Because if the tissue is not compatible, the body's immune system gets angry and basically rejects the organ. And that in humans is called HLA. So MHC is major histocompatibility complex. In humans, it's called human leukocyte antigen, or HLA. You will hear this word when you go to a transplant center, because they're drawing you blood to get your HLA typing. And this typing will play the most important role in kind of getting you to a transplant waiting list and the time you spend on that waiting list. What are these? Is a bunch of proteins that sit on your cells. However, they give you this unique identity. So these proteins make you you and help your body differentiate you from somebody else. They're sitting in one of your chromosomes 6, they're nearly 20 genes, multiple variations, if not 50 per gene with an individual. So every gene is going through 50 plus mutations and giving each of us a different unique identity, making it extremely unlikely that two people will have the same set of these molecules with them until they were identical twins. So that takes you back to the history. In 1954, what happened? They were identical twins. And we did not have this knowledge about histocompatibility until 1964. So we'll go on to the next slide. So what we do is, like, when you match somebody, and this is perhaps one of the most difficult sites, so bear with me patiently. So you all will inherit a certain style or certain set of HLA molecules from your mom or your dad, and you will be kind of a mix and match of combination as a child from them. So you will have your unique type of HLA that sits, your unique identity that sits on these cells. This identity is checked in a form of beads when it comes to transplantation. And then when you are on this list, the doctors basically look for this identity and bead matching. And then if you find somebody who's a close identity bead match to you, they take it and you're called a match. So that is what being a match essentially means, is more importantly, this tissue thing. Next slide, please. Now, how important is this tissue identity? Was it very, like, why is it that we talk so much about it, or get into immunity, or get into HLA stuff? So up until 1969, we didn't know the importance of this tissue identity. And this work, you know, I proudly can say this work was generated, developed, and done at UCLA by this genius man called Paul Terasaki, who now, if you walk in Westwood, has an institute named after him, and he was a big philanthropist. So what he did was, like, he took a look at these, like, 225 transplants that had happened and had gone through rejection, and he found that the kidneys that did not have a good tissue match on it rejected right away or very fast, within a matter of, like, hours to days. So hyperacute or accelerated rejection is something that's happening very fast, versus the transplant that had this match of tissue identity, which means the CDC, if you see, it's the complement dependent cross match. If it was negative at the lower bottom of this column, you saw 187 out of the 195 kidneys worked perfectly fine. So this is a very important aspect of your transplantation, how to be a tissue match to somebody. So it's not just blood groups, it's not just that, it's the tissue match. Next slide, please. So how is it that you kind of not be a match to your brother and sister? You're born out of the same family, you can be that. So events in our life are very important. The time you get to the place of transplant, your body has gone through a lot of things. Some of the most salient things that become important when you talk about transplant and can kind of, like, hinder, if not slow down, the progress of you getting a transplant when you need it, is you having these antibodies, which make it harder to kind of get a matched donor. So how are these antibodies gotten, and what does it mean? So we all go through our immune system getting memorized to certain events in our body. Some of these events are very important and can create a long-term memory, so much so that if we need a transplant at that point in time, they start to become important in finding a match. And these are called sensitizing events. So events that will form a memory in your immune system and have the potential that once a kidney placed in you, they will start to kind of reject, because the immune system is having a memory that this is foreign and will cause a rejection. And some of the important events in play are pregnancy. So women get exposed to a foreign DNA, which is their child, during a pregnancy. You getting transfusions, you having a previous transplant. All of these are big, big impacts on your body to form a memory and kind of get a memory that causes a problem later to say, hey, you know, my immune system has a very strong memory. It's sitting with a lot of information. I'm having a hard time kind of finding a match because it's so unique. And all of this information, your doctor will kind of put in a word called CPRA. And you will hear this word if you get transplanted, because it's like patients know I'm a high CPRA or I'm a low CPRA, which basically means, do I have a lot of these antibodies in my blood that make it a problem to get a transplant, or do I not have that many of these? And it's expressed in terms of a percentage. Next slide, please. So thinking more about like, okay, CPRA, how important is it? So this is just a reflection of a study that was done in like 2016, is like, if you had a CPRA of 99.999%, which basically is 100 but some less, a doctor you would have to go through approximately 300,000 matches to get to a transplant. So calculations, so think about it, if you had a high CPRA, how hard it is to have a transplant or find a match on this list. Next slide, please. So when we talk next about age and fragility and kind of functional status, so I'm going to change gears here. We talked a lot about immunology. I'm trying to get into what are the factors and what other things kind of get into or when talking about transplant. So age and frailty and functional status. And I got a little distracted because there are like a lot of great questions coming in the chat in there. And patients ask, like, what age do I get a transplant? What is age a hard stop? Is a functional status? What does all of that mean? So remember, biological age is kind of a better predictor than your chronological age. Some people, especially when we talk and meet people in America, they are living a healthy life. They exercise, they go out, they have social support, and they're a grade 65 or they are a grade 70. So they do not, no transplant center kind of sets a higher age limit on a transplantation. It depends on that evaluation process, where you are, how you look, how you feel is what is important when you're talking about getting a transplant. Interesting data, but that 20% of now all transplant recipients are older than 65 years. So basically we're telling you to not feel old at 65, but start talking of transplant whenever you want. Stay healthy. If you're healthy, you're 65. I've met people who are playing tennis at 90. I mean, they're great people. The only hurdle, if any, is like, as you age, and this becomes important when the doctor evaluates you, there's early increase in postoperative risk. It's a little uptick if you see data in postoperative kind of like length of stays, postoperative time frames, in time spent inside the hospital when you are dealing with a person who's a little bit elderly. But again, I've seen personally people leave in 3 days and go back to work and do things in their life in 3 months. So compared to when we looked at the data on just elderly people, comparing patients that were sitting on the wait list, transplant recipients get a net 3.7-year increase in their expected survival. This is the data that was existing in elderly people. And if we just did a study of like the octogenarian kidney transplant recipients, the median 5-year patient survival was 55%. So this is a significant number. So if you're not frail, if you feel young, you're active, and you're dealing with just kidney disease and are taking care of all other of your health problems, I think you are a candidate, or you could be considered a candidate for transplantation. Next slide, please. Very important, and it comes many number of times, is obesity. I briefly touched on it when I talked about contraindication to transplant. I'm going to spend a really small time on this, and I put a picture up there just to kind of give you a visual sense how deep the surgeon has to go in to kind of put a kidney. The scar is way smaller than that. This is a very exaggerated picture, but just to give you like, the more the central obesity will be, the more surgically complex the procedure will become. and it's harder, and like the recovery time takes longer, the skin tonicity matters. So that's why, apart from other factors like sleep apnea and everything, patients tend to be told to start losing weight, and then talk about bariatric surgery kind of comes in when a BMI is hitting 35 to 40, because sometimes we completely accept the fact that it's so hard to lose weight when you're dealing with kidney problems. It's not easy. Next slide, please. Now, obesity has kind of an impact in all phases. I put this slide here because I do want people to think like, is it only going to matter when I go for surgery? And if I find a better surgeon, it's going to do better. Not really. Even in the pre-transplantation phases, you can be not sometimes considered a transplant patient, again, if you go to a center where they are not comfortable transplanting you. So it can impact your chances. Perisurgically, if you think, so perisurgically meaning if you are in the OR, post-OR, getting through the transplant, that phase, length of stay, as I said, the surgical complexity of the operation. In the wounds, if they're harder to stitch, they're gonna be increased chances of infections. In dehiscence, meaning they can like open up, cause you to have wound infections, a lot of discomfort, which could be avoided if we were to like not have that. You can have incisional hernias happen and a lot of other things. Post-transplantation, very interesting, but we have noticed if you have a higher BMI, the cumulative incidence, so basically put together, the grafts lasted less long than compared to people who had lower BMIs. So weight matters. Next slide, please. Now, does being overweight is the only thing, and being underweight is okay? No. I think being underweight and overweight both is a bad thing. So I think the emphasis from this slide is basically that whether you look at all-cause mortality, which means death from any causes, whether you look from like how long that transplant graft would last, or put together any kind of mortality, which is graft or you put together, if you were underweight or if you were overweight, it was causing increased problems. Only if you found yourself comparatively in a normal, semi-normal BMI is that you reduce these factors. So focus on health, focus on nutrition, focus on getting healthy, focus on feeling healthy is very important, statistically kind of proven too. Next slide, please. Bringing you to another big of these things, diabetes. Obesity kind of leads itself into diabetes. Now, diabetes is perhaps, if not the most commonest cause of kidney transplantation listing. If you see 10 patients in an evaluation clinic, 6 of them may have diabetes, some form, some version, some strength, some are on insulin, some are not. It again causes you to have poor patient survival, poor graft survival, which basically means the allograft is having a hard time kind of staying in the body because the diabetes starts to affect it again. Even before you get transplanted, having diabetes can also give you problems with your heart. So there's increased incidence of cardiovascular problems, increased incidence of peripheral vascular disease in there. You may have increased blockages happen in your legs where the surgeon's trying to implant the kidney. So remember, the one contraindication was having a lot of atherosclerosis. So the surgeon may have a hard time connecting this graft to you, and this may cause problems downhill, like your leg may lose the blood supply if the surgeon puts a kidney because it sucks away all the blood. And then you can get what's called post-transplantation diabetes. If you begin with a higher hemoglobin A1C level, you will not do without getting diabetes in the future, because like to begin with, you have a higher hemoglobin A1C, bring in a transplant, bring in those medications. The transplant medications also give you some diabetes, bring in those steroids, it causes trouble. So working on your diabetes before the transplant is very important. Next slide, please. Very important, psychological substance abuse. A lot of us are talking about it. So it's a relative contraindication. Every transplant center takes it differently. Takes into account where you were in terms of before your psychiatric state. If you have any psychiatric illness, remember the psychiatric illness will get exacerbated if not. How did you adapt to your stressors in the past? Getting a surgery is a stressor. How are your coping skills? Have you got a history of treatment adherence? If you were told something and you had a medication, did you manage it well? Did you adhere to it? Do you have a substance abuse history? Do you have anxiety? Do you have depression? Do you have health-related quality of life, quality of affect issues in there? Now remember, candidacy is not denied, rather put on hold. So no center will say, there's actually a law in California about marijuana. We'll go into it next slide. But the transplant center will not deny you a candidacy. They will tell you certain goals to establish so that you can get better and return to transplantation. Definitely having a substance abuse contributes to poor transplantation outcomes. Next slide, please. Marijuana, very important, especially when we're dealing in California. So marijuana is this is cannabis plant. You essentially get two cannabinoids from it. So one is THC that you hear, one is CBD, and there's a smaller version which is cannabinol. They're different. They're very different in terms of their effects on the human body. They work on these receptors. I bring out this because they're present in multiple organs, and hence this controversy about what to do when you have a patient with marijuana listing for transplant. CBD is considered non-intoxicating, although THC is semi-stimulating because it's got a primary psychoactive component. What kind of forms people take? People take edibles. People come to you doing oils, vapors, patch, tinctures, plant kind of material in there. They're different kind of like oral, like oil tinctures for pain, nausea. It's finding its way into medical literature. It's finding its way into like medical uses for different things. It has its role. I'm not denying that. And certain people smoke it. Next slide, please. Now, what are the problems and what would make your transplant center think differently about you if you were taking marijuana? So statistically looking from purely a transplant data point of view, purely transplant, we're not talking other, 90% of the patients that kind of came into this data set, they were inhaling in some form marijuana. 10 or less % is what was oral. Now, inhaling marijuana tends to have an onset of action within minutes, kind of peaks itself in 15 to 30 minutes, finds its half-life 1 to 2 hours. Oral consumption, slow, gradual, steady. So the onset of action is like 1 to 2 hours, effects 2 to 3 hours, half-life 3 to 6. Here's where the problem starts. There are certain inexperienced users who will be tempted sometimes to overconsume these edible preparations, leading to drug accumulation and kind of prolonged side effects. Statistically, edibles have been shown to have a higher rate of emergency room visits, probably from these causes, from these factors. And they present with like acute psychiatric symptoms, having intoxication, cardiovascular symptoms. And if you're taking marijuana with fat, it kind of tends to have a higher bioavailability. So what are the different problems that as transplant people, they have tried to put together? And are they so big that this becomes an issue of such long discussion? So cardiovascular seems to have the most data on it. And in cardiovascular literature, we have seen increased atherosclerosis, increased incidence of myocardial infarction happen. Cardiovascular seems to have the most data on it. You see arrhythmias happen. You see ventricular tachycardias being reported, which are dangerous arrhythmias. They are life-threatening at this point in time. Cardiovascular or heart literature is reporting strokes happen, peripheral arterial disease. All of the things we just talked about could stop you from getting a transplant. Smoking marijuana, even though the literature is a little bit old, talks about you getting increased incidence of bronchitis. There's decreased respiratory function that starts to happen, pneumonitis. Aspergillosis has been known because marijuana seems to carry aspergillus spores. If you are transplanted and you get medications, their levels are going to be your life. you will always be talking about levels, and these levels get affected by marijuana at this point in time. Infectious disease, as I said, there's a huge risk of aspergillosis that has been talked about. And then people, especially the people on the transplant world, the doctors, currently on a consensus that if you have an addiction to one substance or your dependence on one substance, it kind of leads towards less compliance. So there's data that kind of like very, very minimal, but that it leads to decreased compliance going forward. It kind of causes increased risk of psychosis just because of the interaction of these medications. Next slide, please. So far on marijuana, there are important statements being issued. So Canadian Society of Cardiology, Canada, which is a fully has cannabis legalized. The Canadian Society of Transplantation requests patients to at least have 6 months of abstinence from smoking, inhaling, or vaping cannabis. Now, this is heart transplant. All the data is coming out of heart transplant. And you can see they're talking about a strong recommendation, even though the quality of evidence is kind of low. They prefer that recreational or medicinal non-inhalation cannabis, and they call it not an absolute contraindication. And this should generate a conversation with your doctor in that evaluation room. And they will refer you to certain kinds of rehabs if they deem appropriate. They would refer you to psychotherapy if that's appropriate. But most of the programs require you to have an abstinence for a minimum of 6 months. What is the kind of takeaway in US right now? US is kind of following Canada's lead. A lot of people are talking about problems with marijuana in heart transplant. So again, the doctors are taking into account the route of administration, the frequency of use, the dependency on this on marijuana in its form. And kind of they're talking inhalation. It's going to be a bigger no-no compared to consuming cannabis through edible and topical products. Casual cannabis has to be distinguished from an actual use disorder. So again, bottom line of this slide is have a conversation. However, most centers would like you to be kind of getting away from marijuana in some form before they completely take you for a transplant. Exceptions available. I've personally been involved in an exception where a person got a transplant, was needing marijuana for medical reasons, and it was important. Next slide, please. Immunizations comes as a very interesting topic these days, especially when we talk about COVID. So all your vaccinations, especially the live attenuated ones, needs to be completed. So all the live vaccines, shingles, measles, mumps, rubella, oral typhoid, they want you to be done before you get started on the transplant or before you get the actual surgery of the transplantation, because once you get the actual surgery, you will get immunosuppression on it, and then you can have viremias from it. COVID-19. Now, COVID-19 is kind of a topic that, again, generates a lot of buzz, a lot of discussion, but most of the transplant centers will not list you. And this I can speak from UCLA's point of view too. They will not list you for a transplant or put you on that list until you're fully vaccinated for COVID. And they have their data, they have their reasons for doing this. So important that you're COVID vaccinated. If you feel strongly against it, have a conversation with your doctors, have a conversation why you feel it, discuss your options. But for now, I think the consensus across transplant centers is before we put you in immunosuppression, we want you to be COVID vaccinated. Next slide, please. Malignancy, many of us have and deal with cancers, or many of our relatives have cancers. Immunosuppression, as I said, will increase the risk for future malignancy. Every cancer is different, and every cancer has to be looked differently. Most cancers find themselves as only being a time-limited no to transplantations. Most of it will get you, the doctor will see you, the doctor will send you to an oncologist, kind of find in what stage you are, and get you ready for transplantation. On the right side on this graph, you see the cancers that kind of come back or impact after you get a transplant. I mean, we've seen people have terrible, terrible diseases after that. Melanomas, Kaposi sarcomas, lymphomas being the most. Many of these cancers that have existed in the past, once you get an immunosuppression, can start peeking their heads again. Hence this discussion, hence this evaluation is very important. Next slide, please. So kind of changing gears here, getting out of our risk factors, trying to find out the kind of deceased donor kidney transplant. So we all know you get a simple living donor transplant, you get a person who has a nice living fresh pink kidney that comes into your body, it's well matched to you. However, what happens when you get a deceased donor kidney transplant? So deceased donor basically is where this conversation of KDPI kind of kicks in. And I will discuss this in the next slide. So KDPI is a basic way a doctor gets to assess what kind of kidney we're picking up. It runs on a scale of 0 to 100%. Most kidneys are either in a bucket of 0 to 85%. So that bucket is all the same, 85% and above. Then there's this thing of en bloc, and I put a picture of en bloc. Some of you may get offered what's called an en bloc kidney, which is a kidney unfortunately coming from a very young baby. The kidneys are small. The surgeons may put 1 versus 2 kidney both in your system, and they don't work immediately. It's a far more complicated surgery. However, the intention is that they're going to grow in your body, take over the function, and over a course of like next 3 months, start and function fully and give you a happy, healthy life. The A2 to A2 we talked about where we cost blood groups. There are special considerations now coming in where patients can get, remember, HCV or hepatitis C has become a treatable disease. So if you have a donor who's HCV positive, can give their kidneys after passing away, and it can come in experimental protocols to a recipient which is negative in hepatitis. You have the special subset of people who have HIV. There's a whole study called Hope in Action. If you have HIV, does not mean you cannot get a transplant. People are looking into survival of like HIV positive to HIV positive kidneys. Next slide, please. Going into KDPI, I put this slide here because a lot of people on our previous chats have asked us questions about the KDPI. So KDPI basically means a kidney donor profile index. Kind of takes into account certain risk factors at the time when the kidney is becoming available. Not a very kind of comprehensive, but attempting to be comprehensive, trying to capture all the major points that may impact the survival of this kidney in a recipient's body. So you see yourself having donor age, taking into account, somebody just asked me a question about donor age. How about race? How about weight? How about the height of the donor? The kind of, if we know the donor had a history of hypertension, whether they have diabetes, what were they dying from? What was their serum creatinine? If they had hepatitis C, and is the donation happening after they passed away from a cardiac death? Remember, heart stop pumping in your body, it will disrupt the flow to your kidney. And when that kidney is coming out, it may be slower to begin with. So it does impact. And this kind of KDPI find its role in kind of predicting. So remember, it's only an intelligent guess into how long you would expect based on the center's experience in the last 10 some years compared to a kidney with a lower KDPI. So remember, the bucket was 85 to above and 85 and below. The lower the number. So you see all of these risk factors, if there are less number of risk factors we kind of dealing with, we expect the kidney to last longer. However, top in red, I do put in the predictive power of KDPI is not great. It's just one of those factors you have to consider in terms of things before you will take that kidney. And when you say a C statistic of 0.6, I'm basically telling you, it's like if you were to base your decision purely on a KDPI alone, you're like flipping a coin. It's a 50-50 call. And then on the side, you see like the rules of thumb. It's like, oh, ideal donor. Somebody just asked about donor age. What is your ideal donor according to KDPI? Age is 19. Their weight is 80 kilos. They didn't die of a CVA. They had brain death, but had no comorbidities. How many, like think logistically, how many 19-year-olds like that would need to die to give donations of kidneys? And how practical is that consideration? Age, how much is the impact of the age of the donor? Now, we are only talking deceased donor. How much is the impact of the age on the KDPI? And a year increase, so a difference between a 40-year-old donor to a 41-year-old donor is basically 1%. Now, comparing this to the race of the donor. Now, this is a very contentious topic because this is not truly a discussion about somebody's race. This is a discussion about how we're measuring the filtration based on race, and things are changing. So you will see this statistic change too, but it kind of reflects how inaccurate it is, how unfair it is that a higher KDPI by 17%. So if your donor was African-American, I would add 17 points to KDPI. Not fair at all, not true in life at all. However, exists something that is having a conversation about change. You're at the height of the donor, how tall it is adds like a 1%, how heavy they were at the time of their death kind of adds approximately 4%. If they had hypertension and diabetes, remember hypertension and diabetes were risk factors for you to get kidney disease. It will be a risk factor for kidney problems happen in the donor. So each of it would roughly add up like 12. What was their serum creatinine? Basically, the doctor is looking at if they had any problems with their kidney or they were going through any kidney stress at the time of when we took the kidney from them, if they had hepatitis C, or if they died a cardiac death. So all this I'm telling you is, even with this much information, this statistic just is like flipping a coin and finding a kidney. Because remember, when people pass away, we do not know everything about them. We try and make the best guess. We try and do the best for you when we take the best thing, but do not kind of just hold your hats to just the KDPI alone. There's a lot more to this. Next slide, please. Important things, this will become your life. Post-transplant medications. A lot of people ask questions about post-transplant medications, anti-rejection. So when you get a transplant, these will be the mainstay of your post-transplant treatment. So prednisone is a steroid. Many of you may have heard about it, have gotten it for your kidney problems. If you had Prograf or tacrolimus is an immunosuppression medication, and Cellcept in a mycophenolate mofetil. Most of the patients, if not all, will find them to be on some combination of these three pills. Every center, remember, is different. Every center follows different protocols. They follow different targets. However, the drugs roughly seem the same. Transplantation or post-transplantation time is also a time where you're at risk for infections. So you get given antibacterial prophylaxis or protection from bacterial infections, protection from viral infections, protection from fungal infection. The dose, duration, choice of medication all depends upon your personal risk factors and the kind of donor you get. So it's something that goes into play once the doctor kind of has a full evaluation on their desk. You've gotten a transplant, we know what's happening. Next slide, please. Now, I want all of you to kind of put that memory of those identical twins and that tissue matching, which was the most hardest part of this presentation to kind of explain. And remember, there was something that doctors got thinking once that first transplant worked. They were identical twins. We didn't have immunosuppression. We didn't have tissue matching at that point, yet they lived. The recipient lived and the kidney stayed in there for at least 8 years and would have stayed longer had the recipient not passed away. So the body in itself had some kind of tolerance to it, right? The body considered some part of it as its own. And this is the introduction I would give you to something that's happening in UCLA and maybe 3 other centers in the country, where people are looking into what it means and try and understand tolerance and do transplants, which will eventually stay in your body, but you will be off immunosuppression. And this whole impetus is about, like, if these immunosuppressive medications have risks, steroid being the most common, steroid had its own risk, tacrolimus has its own risk, cells have the risk of infection. That's why you're on so many prophylactic medications. So tolerance, or understanding how a body is able to consider a foreign organ of your own, is what is the premise of this tolerance program. So this is a trial that's running in UCLA. It's also running in 3 other national big centers, which are each doing their different protocol. But the UCLA protocol is about, we basically take in stem cells from your donor, kind of develop and nurture them. There's a certain subtype of cell we identify. And Dr. Sui, can we go to the next slide, please? And then when you come in for a transplant, we kind of give you some form of radiation, immunosuppression, then transfuse you with the stem cells of your donor, confuse your body, or get you tolerance into kind of confusing it into understanding this organ is your own, and getting you off all immunosuppression by the end of the year. So it's fascinating. It's happening. We've already done 3 successful pair donors for it. Right now, this program is for very well-matched ribbing donors. So essentially siblings who are complete matches to each other in terms of chromosomal, remember, tissue match analysis. They are the ones that are being enrolled. So if you are somebody, and if you think you may qualify for this, please let us know. Please write to us. We will help you get attached to the transplant. This is an investigational protocol. So remember, this is free. The UCLA and Medicare is covering a lot of it. So it's not a big burden on you financially if you want to pursue this route. The doctors are happy to sit, talk to you, and evaluate you for this. Next step. Next slide, please. So I'm going to summarize all of this in like an ABC. I saw a commercial on TV and kind of gave me an idea of thinking about it. So, getting a transplant is all about ABCs. You have to be aware. You have to be aware of what your kidney problems are. You have to be aware of your other medical problems. Where do you stand with them? B, you have to have belief. You have to have belief in yourself that you can do better, that you can be healthier in life. You want to do better things in life. You want to get rid of all your kidney problems, and you have to have belief in your team. And C, you have to take care of yourself. And you know what? All these ABCs, I found them with the UCLA Core Kidney Program. I cannot say much more great things about it. I would just say at the Core Kidney, I have found myself holding hands of people, getting them to understand this. So I would just end this by saying, please write to us, tell us your questions, introduce us to yourself, consider us friends. And I'm going to stop here.
What an amazing presentation, Dr. Sarkar. This was spectacular. We have a lot of questions, and I'll try to go over as many as I can. So here we go. And this is, by the way, being recorded. There was a lot of very important information that Dr. Sarkar went over. Dr. Sarkar has joined the Core Kidney Program. She has been actually in all our meetings answering questions from the back, but also she is going to be presenting a fair bit on kidney transplantation as we move forward. So let me go. So one question I think Mr. Lewinson asked, I think you're talking about the couple. Did they wait 15 years or 50 years?
Oh, great question. They actually celebrated 50 years of having a kidney transplant. Yeah. So one of their oldest survivors. Very proud for them.
Yeah. So Mr. Lewinson actually got a kidney from his wife, a living kidney donation at UCLA, and yeah, Mr. Lewinson has given so much back to the Core Kidney Program. He was also on our trial as well. The other question is, are there contraindications for the donor or the recipient? Obviously, they are contraindicated, and I think you went over them. Do you want to go over them again, or I think the slides?
I would say, you know what? Again, everybody is different, so yes and no. So have a conversation, or you can write to me separately describing your situation, and I can help tease things out better.
Very good. Great. Next question, do you automatically get added to the UNOS if you're on dialysis?
No, you will have to come to a transplant center. They will put you, UNOS is what the list is. So they will feed all your information in there.
Next question, I want to donate to my sister. And Dr. Shah, please feel free to chime in as well, our other transplant specialist. I want to donate to my sister, but my BMI is high. My understanding from the Connie Frank Center is that someone can work with me to lose weight so I can become eligible to donate. Is that true?
Yes, I mean, there are resources that are available. This is more towards the living kidney donation kind of program. But yes, and again, I'll say definitely write to us and we'll tell you more. We'll get you connected. And the next October 1st presentation is all about this.
Yes, yes, very good. And also, we have our dietitians who come on this core kidney program and a lot more in psychology behind eating as well. So there is a lot of combination. Our nephrologists, we are also going to have Dr. Zhao Ping Li, who is the head of the nutrition center at UCLA. She is going to be coming to one of our programs as well. So we will be discussing this, but exercise, Mark Coronel, our ambassador, is an expert on that as well. And yes, so please, but I think there are some resources that are available from the Connie Frank as well. Is there a CPRA number prior to getting a live transplant?
Yeah, fantastic question, I would say. Yes, everybody has a CPR because remember, it is a risk of you having memory in your immune system. So it exists whether you get a living or you get a deceased donation. It impacts what kind of medications and how it plays out in the future.
Yeah, and I think, yeah, sorry, go ahead.
No, I'm reading his question is like, I think he's asking a very good question afterwards too. What is the tissue matching process? It's the blood or biopsy. It's blood. They take your blood at the time of evaluation and send it to what is called an immunogenetics labs. So they look through your immune cell, they look through your genetic markers, and then they find if you're a tissue match or not. Blood is tissue, remember.
And I just want to mention, you mentioned three things, right? I mean, the previous transplant, obviously pregnancy and blood transfusions. So it's very important for every recipient to know that blood transfusion, you have to take it quite seriously. So I always tell to my patients, at least, that if they are being recommended blood transfusion, they really need to make sure that there is an absolute necessity and not just a number. Sometimes if you go to different ERs and hospitals, they see your hemoglobin is low and there are a lot of medications now, and some of them hopefully will get approved in near future that actually help with anemia, and we will do a program on that as well, because that's actually quite common in patients with kidney disease. If the donor is diabetic, metformin recent diagnosed, does it impact the transplantation? So I presume this is for a living donor. But anyways, whatever you want. I mean, I can add my 2 cents on this as well, but
yeah, please go ahead. I mean, I'll let you talk first, Dr. Rastogi.
Yeah, I mean, if it's a living kidney donor, they will not be able to donate if they have a diagnosis of diabetes, because it's a very donor-centric program that we want to make sure that everything is safe for the donor. Now, keep in mind, just because they're on metformin doesn't mean that they will be excluded, but why are they on metformin? And if it's type 2 diabetes, then they can lose weight, they can exercise, eat better. So they are, as Dr. Sarkar said, and I'll just repeat that, there's some absolute contraindications and there are relative contraindications. And if you have uncontrolled or higher blood sugar, now if you have type 2 diabetes, there have been patients who have improved, but that would, in my opinion, go towards more almost like an absolute. But if you make changes and do better, then we will definitely reevaluate you. Now, in the KDPI, and you went over the KDPI, if they are asking about the deceased donor, then it and that's a lot of times is a judgment call. Like Dr. Sarkar mentioned, the KDPI scores is just one tool that we use. There's a lot of others, and And diabetes is the most common cause of patients ending up on dialysis, at least in the US. Great. Do you want to add something, Dr. Sarkar?
No, I think that's all I would say. And then remember again, when you think of what your donor would be, we always look at what if I was a donor, right? What if I was to pass away and I had these things, like would my kidney be healthy for somebody or not? So that's how you have to always think, like the doctor's trying to envision this person, was it alive? How was it when they take the kidney?
Another question, what happens when a live donor is not vaccinated?
I think, they will most of the times not, a donor, it should be different, I think. Recipient, I know for sure, like it's it's a conversation that needs to happen. The vaccines are for your own safety.
Right.
So definitely they will encourage you to get vaccinated. The recipient absolutely has to be.
Right. And also depends on what kind of vaccination. Is it like flu? Is it COVID? And we will be discussing, Dr. Sarkar will be there, Dr. Shah, and also a living kidney donor coordinators will be discussing this in a lot more detail. So any questions with living kidney donors, we can hold it to our next event. UCLA has an age limit for evaluating patients to the UNOS list. So what is your suggestion for getting evaluated if you don't have a living donor and your age is over 75 now? So this is for
yeah, I mean, so that comes very often. And sometimes we do recommend, there are other centers that are pushing the boundaries and are willing to take it. You don't limit yourself. Just because I'm speaking from UCLA point of view does not mean I want you to just come to UCLA. Do what is best, ask around, many places are ready to do it. And many places UCLA is doing this because we have a 10-year wait time attached to it, just because the way we are situated. There are many places where the wait times are not that much. And, by the time you get kidney, or 78 or 77, that's different from UCLA where you'll be 85.
Right. And I think what has been told, and Missy was on our program, I think last time or before, that if you're over 70 at UCLA, then they won't list you here unless you have a living donor. And the reason for that is what Dr. Sarkar said, is the wait time here is quite long. But if you have a living donor, then this is the place to be. And
very comprehensive, a lot of great information. Just to elaborate on the last thing you said about the age limit, and certainly there are other centers that give these patients a chance for evaluation, as Missy last time so nicely alluded to, double listing, or you can, the beauty of listing yourself, not limiting yourself to one transplant center, I think is advantageous at that. So patients should explore and not be limited. It's just because one center has a certain absolute policy, it doesn't mean they're limited. They can explore that either locally or otherwise. And the same thing goes for COVID vaccination and marijuana usage, so on and so forth. And these are all relative, issues that may be dealt with differently at different transplant centers. So I urge patients to explore that by seeking double or triple listing.
Right.
Thank you.
No, thank you, Dr. Shah. And also out of state, a lot of my patients actually go out of state because for deceased donor listing, because the wait time is shorter. But I do want to say one thing about going to other centers, and that's happened. If UCLA is declining you or denying you from getting on the list, or is asking for more information, always question why, because there might be a safety concern for the patient here too. So I know there are a lot of places, in the living kidney donor program at UCLA, we are a bit more conservative, but there are other programs that are much more liberal. We'll be discussing that at an October 1st event. But like Dr. Shah said, it's always good to get information and from other centers as well. And always question, why are they doing something differently than what UCLA is doing? And one could be as simple as the wait time, like Dr. Sarkar mentioned, Dr. Shah as well. So with that, I think we will be ending the program. this is being recorded. It is going to be put on the YouTube channel. If you go to YouTube, there is a channel for UCLA Core Kidney Program, or just put Core Kidney, and there's all patient videos. This will be edited and will be posted. And once it's posted, we will be sending you a notification that it is available. I want to thank everybody, our faculty, Dr. Sarkar, what a tremendous job, Dr. Shah, Mark, Jim Cunningham, and all our Christina, our brewing beans, our living donors who, kidney donors who attended, recipients, very grateful. I want to thank everybody for attending. I hope you found this information useful. If you have more questions in the future, please let us know. But we will regroup next month at October 1st, Living Kidney Donation, and will be co-hosted by Tammy Winchell, who's a kidney donor herself. So with that, thank you very much, and we will see you soon.